Assessing nurses' attitude and knowledge regarding opioids. My name is Ijama Enuku. I'm a student nurse practitioner in my DNP program in Northern Kentucky University. My teachers are Dr. Cooper and Dr. Candilioso. This is 2020. The background is on pain control for ambulatory patients is a central issue for all healthcare providers, nurses' knowledge and attitudes are major barriers. Educational program is a strategy to improve nurses' knowledge and attitude on opiates for pain management. Nurses are responsible for regular pain assessment and medication administration. These responsibilities require an understanding of nurses of nature of pain in relationship to patient's critical condition. So I'll be using a tool for measuring the impact of education program. This tool is called the Knowledge and Attitude Survey Regarding Pain, KASR. The purpose of this quality improvement project is to assess the nurse's knowledge and attitude regarding opioid use and to provide education using ambulatory resources regarding the Institute's policy and to recommend improvement to the care, delivery, and outcome in patients with chronic pain and history of opioid use. Patient education and ensuring safety. Before starting this during opioid therapy, the providers should discuss with the patient, be more realistic, and share the benefits of opioid therapy. Providers have responsibility for managing this therapy. Prescription drug monitoring therapy and urine drug testing. Patient education are the most important thing when you're doing treatment for pain control. We're supposed to be using a validated tool measuring from 0 to 10, 10 being the highest, 0 being no pain. Kindly know how you ask those questions and be very sensitive to their values. Try to document. Evaluate the risk factors for the opioid-related harm, starting from and periodically during continued opioid therapy. Review the patient's history. Try to find out where else they have gone for pain management, which doctors wrote them scripts. Try to know if they're actually taking that medication by doing urine dip or sending out the urine so a more detailed testing could be done. Avoid prescribing opioids as your number one pain medication or benzos. Offer or arrange evidence-based treatment for patients with pain therapy. Depending on the result of your testing, try to start discussing about tapering them off opioids. Frequent prescription writing, try to discuss with them about urine tests, review their PMPs with them. This is the time you could do referrals to this patient. You can actually do about 6 to 7 referrals to this patient. I had a patient, just one patient, that she came in for tooth pain and she actually came in for chronic pain. When I studied my history, found out that she started taking opioids for the past 3 years just from tooth pain. The doctor prescribed 90 tablets of opioid narcotic like Vicodin. So as a result, this patient was addicted to Vicodin. So when I said to, we have to get your urine, at least once a year, we have to get your urine, she couldn't pee. Um, I was very concerned. I said, to that right now it's 2 p.m. Have you peed since you woke up? And the patient said no. To be honest, that she now realized she hasn't peed since morning. So I was very concerned and I said, okay, we're going to do a straight cut, get some urine stat, and we're going to do some blood work. And simple CBC CMP came out this patient is having renal failure stage 3. We transferred to more testing, more referrals, ultrasounds, everything for the kidneys. And she has been complaining of back pain, but she said she fell. So no x-rays was done. So x-rays was done and if it happened that it was the kidneys that were bothering her. She had a cyst. So you see how detailed assessment, just one thing. This patient ended up on nephrologist, from nephrologist. This patient ended up with physical therapy, from physical therapy, occupational therapy, from occupational therapy to pain management. So it's like this patient really got the care that she really needed just from one simple assessment. And this hospital was so helpful. They applauded all these nurses by putting their pictures on the elevator as good team workers and giving them free lunch. So, just from good assessment, this patient was healed from destroying her liver with opioids. She was healed because they found out something to do with her kidneys and diabetes and so many things. So good assessment goes a long way with all patients. So you know through these objectives we're able to learn a lot. So preventing, we need to work with our doctors, find out how we can take care of these patients, f- keep on regular treatment. Intervention, we have to assess patients again, and we have to kind of figure out the type of medications, opioids, and things like that, the causes of the medication. We have to review all that. Then, with the risk management, this is a patient that came in with bilateral knee problems. We are able to figure out this patient had no documentation of urine tests. This patient has been taking so many opioids for the past several years and from shopping doctors. So this patient needs help. Okay, we need to train our nurses. Don't be judgmental. Don't judge this patient, but empathize with them and help. We'll start by educating the patients, educating the families, educating the nurses, getting blood, urine tests, teaching them teaching them to accept that they are addicted to opioids and telling them it is okay to accept it and they need help. This is another patient, another scenario. This patient has been having low back pain for 8 years, was in a car crash. Okay, yes, they started this patient off with morphine, 45 milligrams twice daily. So this patient has been on medication for a long time. She has tried physical therapy. By the way, physical therapy is just like regular exercise when you really think about it. So what do? We have to do it more regularly. They give us homework of physical exercises to do at home. We're supposed to do that regularly, not just one time show. It doesn't cut it. We have to encourage our patients to do it. So patient denied any other prescription has daily opioid is concerned, but it is lacking the UDS. Some of these patients have a lot of stories. Either the moms are taking the opioids, or their family members are taking the opioids, or they could just sell the opioids. So we have to kind of figure out, how do we meet in the middle with them? How do we help them? Because look at it this way, if you don't give them the opioids, there's someone at the corner of the street ready to sell it for less. One Vicodin costs $20, but somebody could sell that same one tablet of Vicodin for $5 or even get it for anything. So no matter how much we try to prevent giving opioids, we have to be extremely careful. It is a war that we have to fight together, not we versus them. It's a war that we have to put our hands, put our heads, put our mind, have an open mind, and accept these patients and help them out. Educate the nurses, educate the doctors, educate the staff, educate everybody, and be friendly and tell them it is okay to be in pain, but this is how we're going to work together to reduce and remove the pain as a team. I must say thank you so much for listening to my video. If you have any question, kindly reach me out in my email, or you could subscribe and let me know your comments. Thank you and have a wonderful day. Ijoma Inuku from Northern Kentucky University, 2020. Thank you. Bye. My references. Thank you.